Recording started.
All right. Well, thanks everybody for joining us today. We have Dr. Levin here today from the Division of Digestive Disease, and he's going to talk to us about a really important topic. It's fatty liver disease, which, from my understanding, we're seeing it all the time, but we don't even know it. So I'm going to quickly turn this over to Dr. Levin and have him provide us some updates on this important condition.
Well, I want to thank you folks for having me come over to talk about this. I particularly want to thank Dr. Cynthia Krieger for helping me hone down on exactly what I would talk about this afternoon. I'm going to be talking about detecting non-alcoholic fatty liver disease. Down. There we go. Okay. Just use it. Okay. So I would like to talk about the clinical scope just to give you some idea of what's out there. I'd like to review the challenges in detecting fatty liver and in distinguishing simple fatty liver from non-alcoholic steatohepatitis. And I'd like to introduce two non-invasive tools for diagnosis, one of which is available now at Ohio State, and one hopefully soon. Here's my case from way back in 1976, before a lot of you were born. 78-year-old woman with type 2 diabetes for 30 years, no alcohol, drugs, or transfusions. Her labs were normal, save for an albumin of 2.7, platelet count of 94,000, and an INR, or platelet count, we didn't have INR then, a proton of 3 seconds above normal. She has a history of coronary artery disease. Her exam reveals a large left lobe of the liver, positive spleen tip, spiders, and polymerythema. She's hepatitis B negative. Remember, we didn't have any tests for hepatitis C in 1976. And a CT scan suggested cirrhosis. So, being bright-eyed and bushy-tailed,
Here, use the left.
Okay, you want
Click outside of there. Give me the mouse.
So with that patient, I wrote a consult being aware of the study from Yale and from Mayo Clinic that diabetics with fatty liver were vulnerable to cirrhosis. I wrote the diagnosis that this patient had cirrhosis related to her diabetes. And her referring doctor, a very smart internist, a very nice guy, called me and told me in 35 years of taking care of diabetics, he's never read a stupider consult. So where do we stand now? Well, we know that 30% of Americans have fatty liver disease. This is a rough guess because, again, we don't have really good ways of surveilling the population. 20% of the 30%, or 6% of these patients, have a progressive disease, non-alcoholic steatohepatitis. We know it's potentially progressive and leads to cirrhosis, decompensation, and particularly hepatocellular carcinoma. The worse the NASH, the more likely vascular disease, such as coronary artery disease and stroke. And the converse is also true. If you have bad coronary artery disease, you're much more likely to have fatty liver. So we guesstimate that 3% of Americans have NASH cirrhosis. And in fact, it can even occur in teenagers. In the study from San Diego County, Hispanics with fatty liver had something like 1% with cirrhosis by the age of 18. Who are the high risks?
Did I go too far?
Went too far, yeah. Okay. First of all, the obese, that's the obvious one. Second of all is metabolic syndrome with hypertension, centripetal obesity, high triglycerides, low HDL, and insulin resistance, elevated fasting glucose or elevated hemoglobin A1C. Women with polycystic ovary syndrome are more likely, and insulin resistance for any type. Ethnic groups differ in their susceptibility, with South Sea Islanders, Asians, Mexican Americans having a greater risk than Caucasians, having a greater risk than African Americans. That exists at all levels of obesity, for instance. Tom Layton did a study when he was in the University of Illinois that showed that even in bariatric surgery patients, African Americans have had fewer than 90% with NASH, whereas Caucasians were high 90s. And of course, the type 2 diabetics are very vulnerable, particularly obese, middle-aged, male type 2 diabetics. Type 1 diabetics don't have insulin resistance, but actually do have liver disease with a different sort of pathology. Going back.
Here, I'll do it.
Okay.
I'll flip your slides for you.
What are the issues in trying to find these patients with non-alcoholic fatty liver disease? First of all, many patients never have abnormal liver functions. We all know that patients, elderly women come in and have their gallbladder out, and the surgeon's shocked to find out the patient's cirrhotic. We know that the ALT and AST are generally less than 300, and when you see the AST greater than ALT, then you begin to think of cirrhosis. Most of us think of alcohol, but remember, with progressive liver disease, cirrhosis of many types, including hepatitis C, for instance, the AST elevation, suggestion of progression. Cholestasis is rare to never with non-alcoholic fatty liver disease. So if you have people with significant elevations in bilirubin, think of something else. Now, maybe fatty liver was a common condition like Gilbert's, but it may be the wrong diagnosis. For instance, one of the very strong differences between alcoholic fatty liver and non-alcoholic fatty liver is cholestasis. If you have a high bilirubin and there's a question of alcohol, it's alcohol. Just because the liver has fat does not mean that fatty liver is the only or the primary diagnosis. Remember, in the obese patient with hepatitis C particularly, but other conditions as well, fat is present. For instance, we had one liver biopsy conference a couple weeks ago with several different diagnoses, but 100% of the patients had fatty liver. They live in Ohio. They tend to be obese. So the presence of fat does not guarantee that that's the primary problem. Imaging is often the incidental finding that detects a fatty liver. That's how we know about it. So you know that you guys are seeing these patients all the time, every day, and it can be hard to see. So you'll get it imaging, ultrasound, CT, MR, and that's when you'll first identify it. If the ultrasound is reported as showing increased echogenicity and the radiologist says this is fatty liver, consider that non-diagnostic. If you send over your patient, you can pretty much know statistically that by far and away the most likely diagnosis is fatty liver. So you don't need the ultrasound to tell you that, and this is a very non-specific finding. The ultrasound is very insensitive, only picking up about 48% of patients, and echogenicity, again, is very non-specific. It occurs with hepatitis and a variety of other conditions. There are 5 characteristics which the radiologist can identify, and if they list them, then you can be more convinced that that's true. Deals with brightness, deals with contrast. And the reason I haven't listed them is because our criteria here are somewhat different from ones I read, so I'll let the radiologist explain that. But I've talked to them of trying to be more specific on why they feel an echogenic liver represents fat. It's not even necessary that an echogenic liver has to be worked up. You just don't know. The CT scan is moderately sensitive and very specific for non-alcoholic fatty liver disease, and the MRI is actually sensitive and specific. Everybody will tell you that liver biopsy is the gold standard, but it's not really. There's a lot of sampling error. And in our study to try to validate the PDFF, which I'm going to tell you about in a minute, even on a 3-centimeter liver biopsy, you'll find tremendous variability in that little small section between what has fat and what doesn't. You can really mitigate the sampling error issue by doing something called the wedge hepatic vein pressure if you suspect that they might be cirrhotic. And while you're there, you can do a transjugular liver biopsy. This is something we do very well here. A lot of times when you see outside biopsies, you got 2 portal tracts, it's almost impossible to read, but our radiologists are very good at doing that combination, and it can be terrifically helpful. So if you're considering a liver biopsy and you think they might have a more advanced disease, this would be a better way to do it. It's also less painful for the patient. Next. Now, what about the non-invasive approach? None of us want to be doing liver biopsies in all the patients. If you calculate the numbers, you know that if there are 100 million Americans with fatty liver, that's a lot of liver biopsies. This is not a radiology problem or a hepatology problem. It's a public health problem. It's a problem for you in primary care. You're the ones who are going to have to manage most of these things. Transient elastography has been terrifically helpful, both in terms of ultrasound and MRE, magnetic resonance elastography. But we know the ultrasound is much more cost effective. Unfortunately, obesity will make liver stiff too with ultrasound, although the MR will do a better job. But it's the difference between $500 and $3,500. You're going to get a lot of pushback from insurance companies and so forth with the MRE. But it is the closest thing to a gold standard for non-invasive. Both are done here. Both are done expertly. we're trying to get the FibroScan, which is a elastography which can be done right in clinic. It's a $110,000 barrier for us, which we've been trying to overcome for the last year or two. That's particularly nice because you don't have to bring the patient back. It can be done right then and there. What about the PDFF? Well, this proton density fat fraction is a very exciting test that we are validating right now. It's interesting. It measures free triglycerides. The only place in the body where you have free triglycerides is in the hepatocyte itself. So you can measure fat in the liver, and no fat elsewhere shows up. And it's incredibly helpful and is certainly sensitive to, so that, for instance, if you lose 5% of your liver fat, it's easy to quantitate. And it's calculated that it will cost between $120 and $140 for a 20-second PDFF. So it's something that's plausible, something you could actually do on your patients. Now, I'm in the process now of working with radiologists to actually come up with a real figure that's workable, something that they can afford to do for us. But I think this would offer terrific opportunity to identify people and to monitor to see how what you're doing is working or not. We all know how difficult it is using weight, waist circumference, BMI, and so forth to monitor these patients. First of all, when you go to the gym and put on good muscle mass, it's going to make your weight go up. It doesn't necessarily mean that you're going the wrong direction. Fibrosis is really the crucial surrogate for progressive NASH. In other words, if you have scarring, that means the patient is looking forward to some difficulty. You saw grand rounds last week. The epidemiologist from Mayo talked a lot about surrogates with cancer. And it's even more crucial here because, with cancer, the patients are going to die in 7 or 10 years if they're going to. With fatty liver, they may have a time course of 40, 50 years. And it's physically and logistically impossible to study them. So you need some sort of surrogate. And I think that fibrosis, which can be measured both directly and indirectly, is the way to go. At least that's the way it seems in 2016. Next, please. Okay. So I think that we have to look for these patients, particularly in those groups. One group we should look at that I didn't mention was people with high triglycerides. If you have the dyslipidemia with high triglycerides and low HDL, those people are particularly vulnerable, even those who are thin. Now, interestingly enough, if you treat the triglycerides, it doesn't necessarily help the liver, but it does help you identify those people. And I think that the first goal is to identify these people, and this allows you to make lifestyle changes, which right now are the things that work best, and also to consider other options. For instance, you have somebody who's eligible for gastric bypass surgery, for instance, that cures 85% of NASH. So this might help sway you, even though it's not considered an indication for that surgery.
Great. Well, we always said we were going to bring high-yield topics to this forum, and I think this squarely fits in that category. I'll open up with a question, and then let me unmute everybody else that's on the line here. Give me 1 second. Okay, so I have a quick question. So the scenario you discussed is really common where, we get an ultrasound or some other report and it has a reference to fatty liver disease. So for the primary care physician, what would you say the next step in that is? They meet the demographic profile and you've got either a CT or an ultrasound that shows this finding. What would you say our next step is?
The first thing I would do is take a dietary history. And this day and age is really hard to do because we're so time pressed. But you want to see what they're eating and also see what their activity is. And the things that really tip you off is they drink a great deal of real sugar soft drinks, for instance. They eat a lot of candy and so forth. So one of the things you want to do is try to limit, particularly fructose, but sugars in general. You try to push them for fruits and vegetables. You take an activity history, and you try to get these people to exercise more. Now, we know that diet works, weight loss works. We know that exercise works, both anaerobic and aerobic, using not the PDFF, but another reasonably sensitive MR technique done study done in Verona. Problem is, it takes a lot. And if you can get somebody to modify the diet and to exercise, it really will work. I think you want to obviously look at the medications. Certain things like thiazide diuretics are more likely to cause it. You know, things if they're on tamoxifen or something like that, it's a problem. You want to get a good alcohol history. You don't want to miss that. And we all know how challenging that is, you know. And I saw an alcoholic, 31-year-old alcoholic with her mother. She abstained, yes. You know, up an OSU My Chart that evening. I lied. My mother was there. I haven't quit. So she was fortunately forthright, okay, but a lot of people aren't. I think if it goes on for a long time, there are several other things you want to be checking. You want to, I think you want to check for insulin resistance. I think you want to probably check for insulin like growth factor 1 just to see if they have growth hormone deficiency. This is particularly a problem in people who have things like pituitary adenoma in the past. But if you have somebody who's had pituitary disease, it's definitely worth checking. And it's amazing how well reinstitution of growth hormone corrects the liver function abnormalities. I had one patient who had pituitary adenoma, and the growth hormone not only normalized liver function, despite the fact she felt so much better, she gained 20 pounds, but her splenomegaly decreased, suggesting that even the fibrosis was reversing after 2 years.
And if I ordered LFTs on these patients and they were normal, does that change any of the thinking about what my next steps would be?
Probably not. Now, it is true that if they're abnormal and they do the right things, that a drop in AST and ALT is probably meaningful. But if they have normal liver functions, it's just one more challenge to monitor them. Now, remember, normal AST for an ALT for a man is 31, and normal for a woman is 19. So when you see a woman with 40, that's not really normal. So you have to keep that in mind. But again, the AST and ALT and alkaline just aren't helpful. And of course, the bilirubin is elevated, then you think of something else.
Great. Other questions?
I have a couple for you. One is I saw this paper about liraglutide in patients who had NASH to try to prevent progression to cirrhosis, you know, and also improve. I think it's phase 2, so they haven't used it in everybody yet. But it also prevented or improved metabolic parameters like A1C. You know, these were not diabetics, but they were free. You know, if there's this big population of fatty liver, but they don't all have NASH, could you see us using that type of drug in people even earlier than when they develop the syndrome? Would that be helpful? I mean, we still have a lot of info to get from that. You know, it's just preliminary, but I just wonder about this class of drugs.
With 100 million people with fatty liver, there's a lot of money to be made, and you cannot believe how many different approaches there are to treatment. We have an obeticholic acid trial that's going to be opening up. But those are people who do have fibrosis, and it requires biopsy.
That's a smaller group.
That's right. That's actually it's smaller than the 6% because many people with NASH don't have fibrosis.
Right.
But that's been very promising. The Flint study showed that in a minority of patients, but still in a significant number, they had reversal of fibrosis in a relatively short study. But there's just so many different drugs out there that people are investigating. If you look at the seminars on liver disease that came out on new therapies, 2/3 of the journal is devoted to studies looking at ways of preventing fibrosis in fatty liver using several different approaches, helping the metabolic profile and so forth. So I think the jury's out in terms of which of these things would be helpful.
I wonder if you could target, though, maybe the people that were likely to go on to it and just you'd be able to use it in a smaller group, maybe more.
I think that remains to be seen. What's really, in the end of the day, what's going to be helpful and practical. And I think there's also a difference in perspective. I mean, for instance, if you have non-alcoholic fatty liver disease but no NASH, if you're a hepatologist, say, well, 5 to 10 year survival is the same with or without fatty liver, so you don't have to treat it at all. I think if you're a primary care doctor, you say, well, 35 years, we know they have increased fibrosis. You people have a much longer perspective than we do. It's like telling a 30-year-old obese guy who smokes, don't worry about your coronary artery disease. You passed your stress test. You would never do that. You tried. You're worried about premature death and disability.
You've been treating them for a long time,
right? And I mean, you're even threatening to treat kids with statins and so forth. But while I mentioned statins, that's something not to stop because you have fatty liver. There's no reason to stop. You have, since particularly since you have an increased risk of coronary artery disease. But in terms of which of these 50 drugs that people are investigating, which approach will work, the jury's out. One of the biggest problems is what is your surrogate going to be?
Right. The other thing is the type of fat. So you have brown fat and white fat, and now there's this new beige fat I just heard about. And brown fat's good. So is there a difference in the fat in the liver? Is it the kind that's,
no,
that versus burns versus transition that might?
No, the triglycerides that make up the fat in the liver for the most part are not thought to be toxic. It's the free fatty acids there that are. But the beige fat's really interesting. Brown fat is what keeps your dog from freezing to death when he goes out in the winter.
Right.
And it's thermogenic. It just burns up a lot of calories and generates heat. And there are ways of stimulating brown fat synthesis or actually beige fat, which is white fat that becomes beige fat under the stimulus of a variety of hormones. The problem is it also increases your ghrelin synthesis because which makes sense evolutionary-wise. If you're burning up a lot of calories to keep warm, your hormones will increase your appetite, so you'll eat more so that you won't starve to death. So it's not clear that you can stimulate beige fat and burn up more calories without also stimulating your appetite, which will counteract the benefit of beige fat. But we all know white fat's the toxic stuff. It produces all kinds of cytokines, lymphokines. It's pro-inflammatory. Does all kinds of nasty and bad things for you. Whereas we all wish we had more brown fat so that you could burn up calories painlessly.
I saw a connection between the gut microbiome and the amount of beige and brown you have. So maybe there's.
Well, actually, there's in the talk I gave, the full talk, we talked a lot about the microbiome, and there are actually microbes. For instance, you have identical twins. One has a microbe and the other doesn't. The one with the microbe will be thin, and his identical is going to be heavier. It also affects inflammation. I mean, it has effect on mood. I mean, there's so many things that your microbiome does. One of the major things it does is it creates leaky gut. So the more toxins from the gut go into the portal tract. It's been known for decades, for instance, that endotoxin is present in cirrhotics livers, particularly alcoholic cirrhotics. And the thought is that the alcohol and the effect on the microbiome, it results in a leaky gut, which allows more of these toxins across, and you can stop leaky gut. For instance, one of the things that rifaximin does, everyone gives you rifaximin to help cut down on hepatic encephalopathy. The theory is it kills the urease-producing bacteria, but it actually has a profound effect on the microbiome, which in effect cuts down leaky gut, so fewer things cross into the portal system. So it's all very, very complicated. And I think if I were a betting man, I would bet that the microbiome is going to be the way that we approach fatty liver pharmacologically. Yeah. Because I think that, but remember, the most important thing you can do for your microbiome is eat an appropriate diet. Some English scientist subjected his son to 3 weeks of eating hamburgers three times a day and showed that a third of his microbiome disappeared after 21 days.
They can do that overseas. Hey, can I open up to questions for folks on the phone? Does anybody have any questions for Dr. Levin? I'm going to ask you a follow-up question. Do you guys have anything? Could you go over a little bit more the imaging studies that you referred to? Let me go to that slide. So I'm gonna frame this kind of like I framed the other question. So for the general internist, seeing patients like this so often in our clinics, of all the studies that are currently available, what would be the course of action as far as where does this play into our evaluation and our follow-up on these patients?
What I do is you have an incidental finding, you see the patient, you talk to them about the things that we know provoke this, you try to correct what you can, we have a very good dietitian who can talk to these people, try to rationalize their diet, improve their activity. And then when about a year after you see them, you're following things along, that's when I would get an ultrasound. I do get an ultrasound with elastography.
Okay.
And if you put down ultrasound, abdomen, liver, it'll come up for you. And right now it's a no-charge item, so it's not even expensive, and not even an additional expense. And if they have, even if they're obese, I would do it, because if they have increased stiffness, that's of concern. Remember, we have a fatty liver clinic. We're always happy to see your patients at any stage. And rather than go through the hassle, just email me. I'll be happy to get these people in because we, really would like to see them. Among other things, we'd like to populate the studies that we're doing, but also to kind of get an idea what the natural history is. So, again, there's no super rush. People aren't going to drop dead in a week or a month. And if you get an ultrasound, a month after the first one, somebody's going to break your thumb from some insurance company. So I would just wait a year, do it then. If there's no fibrosis and the patient's making some progress, then those are people who certainly can handle without having to refer them.
So how does the report read? So I ordered an ultrasound with elastography. What do they actually do during the test, and then what does the report come back?
Well, there's several different mechanisms of doing that. For instance, the FibroScan literally jiggles, and so does the MRE, literally jiggles the liver like a bowl of jelly, and it can measure how quickly it pulses, and that reflects how stiff it is, and that'll give you a fibrosis. And at either extreme, the elastography is really good. In other words, if it's normal, the risk of advanced fibrosis is really low. And if it's really stiff, almost certainly they have either F3 or F4, that is cirrhosis, almost cirrhosis. And that's a real concern in those patients we ought to see. In the middle, all bets are off. Now, our radiologists are pretty good about telling you that. They're telling you, if you have a low middle range, it doesn't necessarily mean so much. And those probably are patients that would be good to get off your hands too and let us see them. Just let us worry about that. But if it's negative, you're in pretty good shape, and it will take years to progress. So you can work on all the various things.
So it's on a scale. The report comes back on a scale.
Right. There are different scales for MRE and transelastography depending on the machine. There are many. Again, there's a lot of money in this. So if you want, I have a monograph of all the different physical measurements. For instance, the one they use is a Philips. The FibroScan is dedicated to determining fibrosis. They use their regular ultrasound machines with software adaptation. So they use Philips machine, and if you talk to one of them, they can wax prolix on the different probes that they use. And so that's an addition. And those generally, the one we use, as I understand it, doesn't generate jiggling. It just measures the transmission speed of the wave through the liver, and then can tell you how much fibrosis. There's one advantage to that, and that is it looks at a bigger chunk of liver. Because remember, these things are not distributed evenly through the liver, and the FibroScan has a sampling error issue just as a liver biopsy does, whereas this probably samples 70-80% of the liver. You'll get a better idea. Again, looking for fat. Fat is so easy to tell on MR compared to anything that would cause echogenicity. So it's just very, very sensitive and specific. But the PDF is super sensitive and super specific, and that's all it tells you. You don't really get other images.
And describe the PDF is referring to, that's not the ultrasound with the elastography. No, that's a different test.
That's a proton density fat fraction. That's a MR specifically programmed. And some of our MRI machines have them. The one here at Martha Morehouse does.
Okay. And the cost on that test is very expensive, the PDF.
No, the PDFF, it's, you know, the guesstimated cost when it was described first in 2013 was between $120 and $140 US. Very affordable.
Oh, okay.
Is that because it's such a short time?
20 seconds, right.
Oh, I
But how it translates into the economics of our Department of Radiology, they're in the process right now of figuring out. But I'm hopeful I'm actually trying to figure out also how much it would cost to do a PDFF and the MRE alone and not the rest of it. Because those are the two features that would be nice to do. If you could just do that and
Like a limited echo for LVH.
right.
Well, we've got 10 minutes to the end of the hour here. Unless there's any last questions, I'm going to wrap things up. Thank you so much for coming out and talking to us. I think it's probably stimulated a lot of people's thoughts about their own patient population, and I bet a lot of people are scratching their heads as maybe, well, I know I am, thinking I'm probably not having the right conversations with my patients all the times when it comes to looking at their liver. I think a lot of people think of obesity and their risk towards coronary disease and things. They don't always, I think, relate to, wow, what could this do to my liver, over my lifetime? I just don't know a lot of people connect the two, but maybe it's an opportunity to try to counsel them at the other, counsel toward the other consequences of their eating habits as opposed to just focusing on heart disease and diabetes, which we seem to do.
This group does die of CAD, don't they?
Pardon?
They can die of CAD because they have the coronary artery disease.
There's a 25% of these patients die of coronary artery disease.
Yeah.
And again, you can look, there's this recent article and editorial on looking at the people with coronary artery disease because you screen for them, a huge number have fatty liver. The difference is, in those patients, you're already treating them. So if you don't have a specific pharmacologic agent and they don't have anything that would lead to HCC, you may not be doing anything different. But if you have a middle-aged, obese, diabetic male, those patients have such a high risk of HCC, even without cirrhosis. Those are the kinds of patients you probably should have us see. Because remember, HCC is the 5th commonest cause of cancer worldwide and the 3rd commonest cause of death. When I was a young person like you, we never saw them. Now we have tumor board, we see 15 a week.
Wow.
So it's a very common process. If you go April 9th to the GI oncology conference, and there'll be a big piece on HCC. So that's obviously another topic into itself, but it's a very common thing in this setting, particularly male diabetics that are obese, middle-aged.
All right. Well, thank you so much. Take care.
Thank you.
Okay, thanks.